we go. This is a new thing for me for sure, maybe for you guys as well. Welcome, Reds, Redwood, the Redwood Empire Dental Society. So I'm happy that Martin invited me here. I tell you, it's kind of weird just looking at a camera in an empty room by myself. So I really wish I could see you guys' faces here with me, but obviously we're taking precautions. So I was joking with Martin actually about, hey, I want to stay home and do a Zoom meeting, present over Zoom, and I blamed it on social distancing, but actually it's because this is the first time I put pants on in like 2 weeks, so. But welcome, yeah, so we have a lecture on growth and development, its relation to airway from infant to adult. So you can excuse the kind of mismatching of slides. You might see that I threw it together pretty quick to make sure that people can get some content while they're at home. So, but first, before I kind of jump into that, I just wanted to talk about coronavirus. I mean, it's obviously here, and we want to kind of mention it and talk about it together. Before I do that, though, you can text questions in, and so Martin will relay those to me, those questions, and I'd like you to type those in as fast as you can. I'll try and answer them right when you get them. That would very much help me as a speaker to know people are engaged and interacting and involved, and so please ask questions early and often. But the coronavirus, so yeah, I have a little funny, I'm sure you've seen the videos on how to wash your hands like a zillion times, but this is an alternative method. You can, you don't want just kind of some highlights, the first one's obvious. There's nobody in this lecture right now, so the personal becomes dangerous. So trying to do all your appointments, trying to do as much things as you can from your home is going to be the new norm. I think that hopefully that we're looking for a decline in polarization. I'm looking forward to that, to not seeing my Facebook feeds of people arguing with each other, and I've already been seeing that we're all in this together. So let's see, so some other things. So virtual reality, I'm going to talk a little bit about virtual reality in dentistry and how I'm kind of implementing a very minor version of virtual visits. But telemedicine kind of goes right in there as well. So a Zoom meeting, or there's doxy.me meetings that you can use to at least talk with your patients. I know in dentistry, I think that there'll be, people will be more trusting in scientists. That's what people are predicting. More trusting in experts and actual experts. So, watching where your source is coming from. The rules we live by won't apply. So the world's already changed, and so the environment we live by and agreed upon by has already changed. And so looking out for how those rules will change and how they'll affect us, that's definitely applicable to dentistry. So voting by mail will be the norm. Inequality gap will widen. less communal dining, but more cooking. I already noticed for myself, I'm cooking a lot more and realizing how long it takes to cook. I didn't realize that. So, but I'm also trying to support local restaurants. You know, those guys are hit hard just like us. So they're just breaking even by doing takeout. So, but if you have a chance to read the article, really good. I kind of used it to talk about, for us, how it might change dentistry. But virtual dental care, it's not going to be a 100% ever unless you're trying to do like a Smile Direct model, which I don't think many of us want to do anything like that. But it could be a hybrid situation where there's some follow-up appointments or some initial consultations that could be done virtually to maybe help your practice. So that's kind of what I'm envisioning for mine, to when we come back, if there's pent-up demand, to kind of see some of the other demand virtually. So increased infection control standards as well. I've been seeing a lot about this. I actually talked to Eve Cuny, who's infection control specialist at UOP. She's on the ADA website, if you haven't gone there yet, for resources on how to kind of deal with infection control from the ADA standpoint. Trust or distrust in dental professionals. I mean, I think they're going to trust us more as an expert, but maybe distrust going in our office unless we can show that it's a safe place. So we all kind of got to be cognizant about what's the new normal, and like how do we build that trust that people can come back in our offices when it's time to come back in. So, and then greater than ever adaptation. So if you haven't read the book, or there's a YouTube video, Who Moved My Cheese, it's cheesy, but it's really applicable to this environment we're in. So I highly recommend people look at that, because the faster we can adapt to change and move on from the way it's been in the past, the better off your practice will be, the better off dentistry will be. So this is that website, ADA. It's really good. I've gone through all the modules and looked at all the videos they have, and it's dynamic. It's changing every second. So. So talking to Eve Cuny, she's actually the Director of Environmental Health and Safety, Associate Professor and Assistant Dean. I got her on the phone and was kind of just asking, I'm giving a lecture for the Reds Dental Society, and she recommended reviewing CDC guidelines. So there's a link if you go on CDC and look up transmission-based precautions. Contact droplet respiratory, there's different levels of the infection control you have to do. And the issue is most dentists are trained in a below, like in a standard precautions, universal standard precautions. So reviewing that, and we're not knowing, there's no advice, like there's no, the ADA is not giving advice on new precautions yet, as far as I know, but just reviewing them to know if you had to implement them, what that would be like. And if you could change your OSHA handbook and the guidelines in your handbook, although it's a dynamic system, so you might have to change them now, and before you go back, change them again. The respiratory preparedness plan toolkit is another thing she had me look at. It's kind of it's on Cal OSHA. The CDC has one. Also, the California Department of Public Health has this, and it's kind of made for hospitals. But you can take and adapt it to your dental practice as well. And I say number 4, plan how to acquire N95 masks is what I meant, and who will do your fit testing. So the problem is I've heard a lot of dental offices are ordering N95 masks from wherever. It's probably hard to get right now, but Eve was letting me know that you have to do that, but you have to have somebody who's experienced in how to do fit testing with them. I think we can all learn how to do it and figure it out, but it's not just as simple as buying the N95 mask. And then another thing we're talking about is airflow, negative, positive pressure filtration. Obviously, if somebody has it, you're going to have negative filtration, but maybe there's going to be something new with positively filtering your waiting rooms, so as the new standard. So, but none of this is what I'm saying is a standard. This is all going to be kind of figured out as we go along. So for me, what I'm doing, I'm going to show you guys this video.
Really important for an accurate diagnosis. Here are 4 quick tips. Great pics. Using a smartphone works best. Having a friend take your photo is better, but selfies will also do the trick. Use a flash, or make sure you have good lighting, and get really close to capture only your mouth, not your entire face. The first photo is of the front of your teeth. Bite down on your back teeth, relax your lips, and use 2 fingers to pull the sides of your mouth to expose your teeth. If you're taking a selfie and can't use both hands, bite and smile big to show as many of your teeth as you can. Your final photo should look like this. The second photo is of the left side of your mouth. Bite down on your back teeth. Look to the right, relax your lips, and pull your left cheek back with one finger. Your final photo should look like this. The third photo is of the right side of your mouth. Bite down on your back teeth, look to the left, relax your lips, and pull your left cheek back with one finger. Your final photo should look like this. The fourth photo is of your top teeth. Open your mouth really wide and tilt back your head. Your final photo should look like this. The fifth photo is of your bottom teeth. Open your mouth really wide and tilt your chin down. Your final photo should look like this.
Katie, everyone's been kind of upset with the disruption of Smile Direct Club, but one thing they did have that was good was an app that patients can take their photos and kind of get the ball rolling with. Well, they don't do anything as far as the physical exam. But how I'm using this is not for new patients. I don't think anybody is getting new patients right now during this. It's more for my existing patients to be able to communicate with me. So rather than set up a lot of virtual visits or virtual consultations where I have to be live with them, they are texting in these photos of themselves. And our system, it connects the phone number that they text in with their chart, but you could also just have them put their name and email them. It can be as simple as that. So this photo, this video is from a company that I work with called SmileSnap. I'm a customer of them, but you can use this video. They said that anybody can use a video. It's on Vimeo or YouTube, and it's called SmileSnap, and you can just basically do an email blast to your patients and have them do this if you want. Why I think it's nice is just that you're able to communicate and provide some value to them in case they have questions about their teeth. We're using it, if somebody has a question about a rubber band or the way their braces are on, that's how we're using it. So, but yeah, I realized I haven't even talked about myself, but I kind of want to introduce with COVID just because it's very applicable. But I'm Jordan Lamberton. I'm an orthodontist in Napa and Petaluma. This is my daughter. We had her about have like that little mini kind of topic on COVID-19 because we're all experiencing it. So I think there's a lot more to come. So I'm just being adaptive and taking new information as it comes. But growth and development in Airway is what we're talking about today. So I think it's very important. I mean, it's an important topic because it's beyond just orthodontics. It's beyond just straight teeth for me. I'll tell you how I kind of came to this. Well, first, my background: grew up in Napa, somewhat close to Sonoma County. Went to Irvine, then University of Pacific, and Denver for my residency. Have started my own practice in 2014, and then I taught for a little while at UOP, and then once I acquired the practice from Dr. Claudia Carchia in Petaluma, stopped teaching. But I love education, I love lifelong learning, and so I put just some of the organizations that I've been involved with lately as far as for education and organizations, and I think that's important. And I was going to put another slide here about all the people who've been mentoring me and colleagues along the way, especially in regards to Airway. But I'm just so appreciative of the education they've given out, and I'm by no means an Airway expert. I don't think anybody is, but I've taken a lot of courses to be able to combine this and combine the data and kind of show you the data that I've learned. That's what I'm excited about for today. So my story kind of began with this. I read in the magazines, probably like a lot of you did, about, oh, you can do a sleep apnea practice, make these mandibular advancing appliances. And so as I'm kind of starting my practice in orthodontics, I thought this would be another revenue stream, to be honest with you. But then as I got into it, I realized, well, I don't really want to do that anymore. I mean, I do some mandibular advancement appliances still for patients, but as an orthodontist, I feel like I can do so much more for patients as long as I see them early. And there's some other techniques we are going to talk about in this lecture about what I can do for adults as well that has nothing to do with the mandibular advancement appliance. And so a big mentor of mine and friend of mine, Jeff Rouse, I met him before he was with Spears, but he really influenced me in like, okay, we can do a lot, because the mandibular advancement appliance is like a Band-Aid, in my opinion, for the real problem. And some people really need it for a short time, but it's nice to be looking either earlier than when they need it, or if they have it, what are the other options we can have to have a more permanent solution? And so he kind of really opened up my eyes to all those avenues. So kind of touched on this, but the very simplistic model of sleep dentistry is identify sleep apnea patients in your dental practice and refer for a sleep study, and then control with a dental appliance, a mandibular advancement appliance, if appropriate. And the problems with this is very similar to the medical model for sleep apnea as well. It's just that you substitute the dental appliance for a CPAP. So like for me, I went to Kaiser, got my sleep study done. Turns out I have mild sleep apnea, probably due to a little bit more weight than I've had before. And but their solution was get fitted for CPAP. And they, of course, they said, you know, control your lifestyle, lose weight, that kind of stuff, which I think we should all be saying. But it's kind of a limited scope view. And so the idea of this lecture is to talk about that's great, and if you have that in your practice, that's a really good solution for a lot of patients, but we also need to be looking at other options for certain types of patients. So the limitations are you solely are focusing on patients with apnea, and as I'm going to kind of show here, that's the end stage. That's the most severe, significant stage of the disease. And you kind of get blinders on to anybody who doesn't have apnea but still has sleep breathing disorders. And so compliance, although better than a CPAP, is not ideal. And it controls the problem, but it doesn't correct it, like a Band-Aid. And sometimes you get over-treatment and TMD side effects. Anybody who's used these long enough, you're going to get patients that have these kind of issues. Obviously, the more you use them, the more you know how to get around that. So an airway health timeline. So obviously in utero, we have kind of where it can start is like genetic or pathogenic problems that can cause craniofacial abnormalities. That's where, you know, you can start to see problems with airway because of not necessarily environmental, but more like genetic defects or problems with pregnancy. You know, cleft lips, palates, all sorts of the craniofacial abnormalities. Birth. So this is when it really starts for me. I think that there's some good data that suggests that breastfeeding is very important to development of the airway and the craniofacially. So I'm just trying to give an overview. We're going to go a little bit more specific into each of these. 6 months, we talk about baby-led weaning. I'm just going to be honest, that's not like a research-backed thing, but that's kind of when I go through the theory of why this is happening, how it makes sense to try and give more solid foods to children as they're growing. So 6 months to 2 years, then who can be looking at them is maybe a myofunctional therapist. ENTs can start to look at that early as well, but a lot of them won't want to do any like real procedures until they get to 3 because of general anesthesia concerns. So, but also this is where I've expanded my practice, is being able to see 3, 4, 5-year-olds and do something for them orthopedically, so that we can, if they need it, if they have a sleep breathing disorder. And that's kind of the same time that ENTs, if there's an issue with tonsil adenoids or other issues, will start to do procedures as well. 10 to 18 years, this is where it kind of starts to set in, like growth stops, so you have limited control on the anatomy changes. And so, but a lot of times they're young, so some of the airway issues are hidden away because they can compensate. when they get to 18 to 30-year-olds, this is typically not where obstructive sleep apnea shows up unless there's a significant anatomical or weight problem. But what can happen is we'll talk about this later, is the obstructive, the UARS patients, so kind of a subacute, not sleep apnea, but you're getting lots of arousals and not getting good sleep. This is where that kind of shows up. And these are your classic TMD patients that tell you they can't sleep, or they go to sleep and wake up and can't go back to sleep. And so 30 to 50-year-old, that kind of continues, and some people start to get into the mild sleep apnea category like me. And then 50 to 80, this is when it starts to get more significant. And that's when people are on CPAP, or they're doing kind of the end stage solutions. There's it's slipping on, I'm slipping on the name, but there's almost like a pacemaker that can stimulate the tongue as well now, in combination with CPAP or in combination with the mandibular advancement appliances that we're doing. But I guess the timeline does make it seem like it's all one continuous disease. I don't think that's true. I think it's more that this is what happens at these certain ages. So it's not necessarily that somebody who's a mouth breather automatically is going to get sleep apnea when they're adult, but it might be more likely. And these are the stuff that we don't have data on yet. So, but I was just trying to give an overview of airway and how it kind of ages, how we age with it, and the problems that can happen with it. But first I want to step back to the why of why are we talking about this. And so that was more focused on airway. This is more focused on growth and development of the jaws. So what's interesting that I find is that you go back, and not that far back even, but obviously hunters and gatherers, our ancestors, had a different type of jaw structure, and you'll see stronger masseters, much more alveolar bone, straight teeth, functional third molars. The modern industrial, it's smaller, weaker muscles, smaller, less dense alveolar bone, more crowded teeth, more third molars. So obviously orthodontists would have done well in a hunter-gatherer society, and the archaeology behind this is showing that it's pretty much with the recent industrial revolution. So even in some societies we find where in Aboriginal societies we see that they still have more of our ancestral type of jaw structure. And so what I'm kind of just showing here is that what I learned in residency was that it's all about genetics, that genetics kind of determines your malocclusion, determines your bones. And I think we're all genetically predisposed to a certain way of growth, but there's obviously, in my opinion, environmental factors that are influencing malocclusions, the size of our jaws, the amount of bone. So this article postulated when we went from a hunter-gatherer to a agricultural society that the diet is what is contributed to it. And that might be true. It might be part diet or part whatever else we're doing as a civilization. So kind of similar to like the coronavirus right now, it's spreading so fast because we are using planes as technology and our just the speed of which humans travel now. So so this was a study that just showed that even in 8th century BC that they had orthodontics being done, but when you actually look at the article, the researchers noted that the skeletons, then the jaw sizes were relatively normal, but they were using it just kind of for minor tooth movement, basically. So, so even Darwin talks about this. To me, this is a good show that it's not a genetic variation that's happened. It's a environmental effect on that's affecting the phenotype. So not a genetic effect that's affecting the phenotype. So his idea was soft cooked food and using your jaws less would cause that.
Dr. Lamberton, we have a question.
Awesome.
One of the somebody asked receive requests from lactation specialists requesting frenectomies on lip and tongue, and how does that affect airway development?
That's great. That's a great question, and I have it later, so I promise.
Repeat it, so
I'm going to repeat that. So if I got the question right, is how does lip and tongue frenectomies affect airway and affect growth? And I promise I'll go over that. So thank you. Great question. So you can tell my PowerPoint's a little bit all over the place. So thank you for asking that question, but I promise I'll get back to it. So it's funny, the guy's name was Mr. Brace, was a philanthropist, was removing some of the molars because the jaws aren't growing long enough. So I'm building the case. I mean, just because, there's not a lot of data behind this. It's just more, sometimes as scientists we use observation and anecdote, and I don't think there will be a lot of data behind this, and even growth and development and airway and how they connect, because it's a very hard thing. It's a very complex system to study. So, and so I'm not telling you what, that this is fact, or, I'm telling you what I see and what I've read about and other experts and what they believe as well. So, so this is, sometimes we find these articles that people write way back when, and they kind of get forgotten about. And then as you see that the science is proving these things, that they were on the right track. So this book, it's really good if you have a chance to read it. It's Malocclusions and Far-Reaching Effects by Samuel Adams. And this was written in 1922, but just some of the highlights of it, that normal occlusion goes hand in hand with well-formed jaws, sound teeth, proper mastication. So normal speech, normal brain development, and well-being. So he's already making the connection between airway growth and development and cognitive development as well. So malocclusion always indicates abnormal functioning. Normal occlusion means health of teeth and surrounding parts. So malocclusion does imply a pathologic condition of the teeth and surrounding tissues. So once we make the malocclusion, you can turn over to the orthodontist. The rhinologist, that would be the ENT, should be consulted to determine to treat any mechanical interference with breathing. So they're already kind of working interdisciplinary back then, at least he was, to get him to the right spot. So let's see. So treating the deformity before the 6th year ensures not only good mouth functioning, but also correct breathing. So this is one, the American Association of Orthodontists recommends that orthodontists start to see patients at around 7. I think if we start to include airway patients, and when the dentist doesn't diagnose airway problems, but when they see signs and symptoms and gets them started on the referral pathway earlier, I think for certain patients it makes sense at 2 and 3 years old, or earlier is even better, at least to evaluate. Not that something's going to be done, but that's why I think dentists and pediatric dentists have to be really involved in looking for these signs and symptoms. Not diagnosis. That would obviously be done by a medical doctor. But nasal breathing does not usually follow after the removal of adenoids. And so there's some studies that show that tonsil adenoid removal does help breathing, but they show it can return, or the hypertrophy can return if the patient doesn't learn how to breathe through their nose. And we still have mouth breathers from month to 3 years after removal of tonsils and adenoids. So obviously, again, orthodontics, the width of the nasal floor is dependent on the width of the upper dental arch. So the roof of the mouth is also the floor of the nasal sinus. So if we expand that, we're helping 2 different situations. We're helping more space for the tongue, but we're also increasing the nasal volume. There's also some other physiological changes that happen near the posterior of the maxilla that I'm starting to figure out that it's not just about nasal volume as well. So there's other physiological factors that we're just now finding out about why expanding the maxilla can help patients improve their nasal breathing and lower their sleep breathing disorder issues. So active nursing has a disadvantage of developing the mouth and jaws to a higher degree. And we're going to talk about growth theory as well. So this is actually just more intro to get you to the why I think we believe, I'm trying to build the case that there's a connection between growth and development and airway. And so narrow jaw development causes the tubes to be curved, and so they tend to be closed. This causes deafness or impaired hearing. You also hear parents talk about gets a lot of ear infections. So there's a lot of connection between all these things. So this is pretty well documented in all orthodontic literature and all dental literature about what a long face syndrome or adenoid facies is. And so you can see these patients. These are the very obvious ones when the kind of the ears stick out, the face looks a little bit longer, the chin's maybe back. There's maybe a nose that's kind of crooked down. Maybe there's bags under the eyes. So. And so the issue I have with this, and these are some of the features: pinched nostrils, open mouth posture, elongated face. Like whenever I ask these patients, it's like, oh yeah, I can't breathe out of my nose, and it's pretty obvious that. And so the thought is, well, is the genetic growth what caused the fact that they can't breathe through their nose, or what was the chicken and the egg? Which one caused which? And I don't know that we know, but I do think that if you look back when they're younger and we're able to catch them, maybe you can lessen the extent of the growth. So we want to modify growth early by changing the environment as early as possible. And so I used to believe that it was just all genetic, but I don't believe that anymore. And because of working with young kids and seeing how we can change them. So, but these are the kind of patients that you look at: steep mandible. This thing's a vacant expression, so they kind of look like they don't know what's going on. Prominent upper teeth, high arched palate. So, so this was a patient that the dentist noted. It's interesting. The first photo, you can see his jaw is more prominent and defined, and then later on, I think it's like about 5 years later. And the only thing the parents could find that was a difference between the two was he got a hamster. So the thought was, this is purely anecdotal, but the hamster is what can cause that. I think there's something to that. I think we are in the area we're at. There's lots of pollens. There's in the industrial world we live in now. There's lots more things that can interfere in our nasal passages. So, but here's kind of two examples of how normal growth occurs and how mouth breathing growth occurs. So you can see it's more horizontal. And I would say even that normal growth, again, is the normal society we're in now, but not probably normal as what our ancestors grew. So, this is a great book. It's by Paul Ehrlich. He's a PhD at Stanford, and looking more anthropologically at things, basically, and why did our ancestors have more robust jaws, larger jaws, and all their teeth fit in there. And so, so he said the museum he worked at had ancient skulls, and most of the skulls were just from the last few hundred years, or from our dentist nightmare. So last few hundred years, kind of similar to ours. Cavities, infections, teeth are crowded. But if you go back farther, in the pre-industrial farmers, they did have some cavities, but less than 5% of them had impacted wisdom teeth. So they all had their wisdom teeth. So it's not enough to say this is not evolutionary. This is a microevolutionary event, which is more likely to be environmental than it is genetic. So, so growth. So some definitions here. Just kind of step back. Growth refers to an increase in size. Another way to think about it, it could be normal changes in the amount of living substance. It can also be an increase in size and numbers. So, so the differentiation between development is growth is an anatomic phenomenon, and it's quantitative in nature. So development, it's a progress towards maturity, and it involves differentiation of the cellular and tissue levels. So development is actually physiologic in phenomenon and qualitative in nature. So that's kind of what I was talking about with the airway. We'll get to this a little bit later, but when we expand, we're all numbers driven. We're all quantitatively driven because we're scientists. We don't have numbers. But there's the qualitative is actually what matters more to me. it's a physiological change. If they can breathe better, they can breathe better, regardless of how much you showed on a CBCT, how much the airway volume increased. So differential growth. So obviously, going back to the roots of growth and development, it's just this concept that different organs and tissues grow at different times. And so the Scammons curve obviously is an easy one. We know that the lymphoid tissue has a big bulk up there. And this has kind of been a reason why people say for tonsils and adenoids, well, there's going to be a lymphoid growth, and so it may shrink back down. But and so again, it's not about the visual sight, the anatomical, especially if it's at the certain time period where you expect to have increased tonsillar size. But it's the symptomology. What is the patient? Is that size affecting the patient? Are they not sleeping well? Because then something probably should be done. Because as they're growing, it's a very important time for their brain development, their jaw development. But we also have, besides the different types of tissues, we have a cephalocaudal growth pattern, which means that the maxilla is going to grow more in relation to the skull size, and the mandible is going to grow more in relation to the body size. So that's why we have a later a differential growth of the mandible, and why, as orthodontists, we can have somebody who's class 2 mandibular deficient, and we're able to correct that and maximize their growth. But they're helping us with that. The growth, the differential jaw growth is the real secret sauce about how we correct class 2s, so without jaw surgery. So different theories of growth. There's still theories. I hadn't looked at this really a lot since residency until I was putting this presentation together. But I was hoping there'd be more definitive stuff. But it's just hard to know. It's hard. Like, people are looking, and this is actually for bone, for skeleton. So how and why does a skeleton grow? And so the first was a genetic theory, where it's just the genetic information in our DNA caused our bone to grow a certain way, and that was largely debunked. Because obviously there is information in there that's influential, but it's not the sole. It's not what drives the growth of the skeleton. Then there's a sutural theory, which is that the suture is where the bone's deposited, but it's also a center, and that was also debunked. That it's just really a growth site. So pressure gets exerted on a suture, and it responds. That's how we expand the maxilla, and that's how we expand any suture. And so the next one is cartilaginous theory, so that cartilage gets put forward first and then is replaced by bone. And this actually, in certain parts, this makes sense. This is how this works, is that the cartilage comes first and then is replaced. But it doesn't account for all the systems of the body with the skull. The one that has the least holes, I'd say, as far as the theory, is the Melvin-Moss functional matrix theory. And that's that the growth of the skeleton is a function of how soft tissue grows, how the muscles work. And so when we'll get back to the frenectomy and breastfeeding, but if you're working those muscles more breastfeeding than bottle feeding, the theory is that would cause an improvement or maximization of growth towards what our potential could be. And so another one is the brain. So the brain, the size of your skull is obviously determined by the size of your brain, because as the cells of the brain replicate, then the sutures in the skull respond. And so a lot of our bones are similar in that regard to the soft tissue that causes it to expand. In certain places, cartilage actually goes first and then is replaced by the bone. So some other definitions of airway and sleep breathing disorders. I think probably most people are familiar with obstructive sleep apnea, OSA. Oxygen saturation is, when you have these apnea or hypopneic events and the oxygen decreases in your blood. That's a desaturation. The respiratory effort related arousals, and I have to read these off there because I just call them RERAs, but it is a arousal caused by respiratory effort. It's not an airway or oxygen depletion. It's just that you're getting aroused. So it's more of a I'll come back to it, but it's more of a neurologic or a brainwave issue because your sympathetic nervous system's getting aroused, and so these are the patients who end up having upper airway resistance syndrome, because if you have repetitive increase in resistance to the airflow, you will have a lot of RERAs leading to daytime fatigue. And you also have kind of more stressed out, more cortisol levels because of that sympathetic nervous system increase. So apneas, breathing stops for 10 seconds. Hypopnea is partial airway blockage and reduction of airflow of 50%. Apnea hypopnea ignex is kind of combining those. Respiratory disturbance index takes the AHI and combines that with RERAs. So I have a handout too if you guys want that has all the definitions on there, but I'm just kind of going quickly because I'm not sure what people's different levels of this are. So, but just kind of an introduction still. So PSG is the polysomnography that is the in-lab test. So when I got diagnosed with Kaiser, they gave me an at-home test, and there's some problems with that. Specifically, it's even the WatchPat has trouble deciphering the sympathetic nerve activity. So you can miss. I think you can miss some of these upper airway resistance syndrome patients, and they think they have a clean bill of health, like no obstructive sleep apnea, I'm good, but they have some other sleep issues. So pulse oximetry, obviously how you monitor the saturation level, CPAP, and mandibular advancement appliance. We kind of talked about that. And so we all know that an AHI of less than 5 is normal, 5 to 15 is mild, 15 to 30 is moderate, and over 30 is severe. And so another issue, kind of the same way I'm talking about with quantitative measures, is it does not give justice to the entire story. So there's a lot more coming out now with airway and sleep health about these are best we have right now, but there needs to be more measures in place to give us a more qualitative look at the patient. So when do I want to start intervening? Well, as soon as possible, because I think the big three that are influencing facial development are nasal breathing, lip seal, and proper tongue position. So I think if you have those in good fashion, you're maximize the potential of growth. So obviously we know the maxilla goes down and forward from the cranium. But if you think about this, if Melvin Moss, if we accept the premise that it's a functional matrix of growth, well, if you don't use the muscle and your nose is not being used as in function, how would we expect that any of the surrounding structures would grow to the proper level? If it's not needed, the body says, okay, we won't grow. Kind of the same thing with the tongue at the roof of the mouth. It'll form the width of the palate. It also prevents the maxilla from growing down too quickly. So we have that pressure. So everything's optimized. And when you take somebody who's a nasal breather and you turn them into a mouth breather, that's when the growth systems, I think, get a little off track than what they were supposed to be doing. So this is a study by Eli Harvold, who took primates and sewed beads in their nose so they basically turned them into mouth breathers. And turns out that all of them, when they did that, became open bite. They all became mouth breathing. So their jaws significantly changed once he did that. So we do know that changing someone from a mouth breather to a nose breather to a mouth breather will have an effect on their skeleton and their teeth. This is a video really good video of how breastfeeding is how muscle is influenced by breastfeeding, and kind of this will go along answering the questions of the frenum, but not yet. I have another slide on just frenum, so.
Ultrasound of a breastfeeding infant shows just how important the tongue is in obtaining milk from the nipple. Although looking at an ultrasound video may be confusing, let's take a closer look at what is going on with the help of an animation. Note that the tongue moves not only back and forth, but also vertically. Without both these motions, which may be constricted by a tongue tie, breastfeeding may become difficult and painful. Anterior tongue tie constricts the tongue motion shown in blue, which is the front part of the tongue. The area shown in red is constricted by a posterior tongue tie which limits the tongue's vertical motion in the back. When the tongue is able to move freely, effective and painless breastfeeding occurs.
Okay. Yeah, I just like the ultrasound here. Here's another video I show patients regarding, so that was more breastfeeding, how that can affect
normal or
muscles.
physiological way of
How
breathing
breathing
is
can
through your
affect
nose.
the growth and development as well.
Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth, and your tongue resting on the floor of your mouth, with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
Yeah, so as I was thinking that, I kind of was watching that. I hadn't seen that with the events we're going through COVID, but like obviously we're now talking about wearing masks to filter the virus. And you think about the same analogy, the nose is the best filter versus the mouth. So when you're doing what I'm doing right now, a lot of talking and breathing through your mouth, or you're exercising, you don't give your body that chance to filter, and it puts a lot of strain on the lungs, on the rest of the things. So as much nasal breathing as you can is beneficial for growth and development, but also just being healthier. And so that kind of showed a trend, like a timeline of how that all happens. It probably happens more in congruous with, not using the right word, it probably happens all together more than that sequence, and it doesn't happen the same for every person, obviously. So, but it's a really good video if you want to show your patients. So I asked the question of, because of the airway growth and development, when do we want to start intervening? And the answer for me is always now. So if there's an issue, earlier the better. So breastfeeding, frenum, allergies, binkies, habits, nasal versus mouth breathing, baby-led weaning, which is the idea to introduce solid foods, harder foods quicker, kind of more what our ancestors would do. Myofunctional therapy goes into that, so getting them with a myofunctional therapist, or if you have techniques yourself to do with them. So again, why is it so important in children? Well, children need 10 to 12 hours of sleep. Fatigue reversal, biochemical refreshment, immune function, memory, physiological well-being. Martin and I were talking about, we thought a lot of dentists right now were probably spending up until the wee hours of the morning. Like, if you're like myself, I'm not getting good sleep, which is terrible for immune function. Like, we need immune function right now, and we're all like stressed out and not sleeping. So this could be the most important thing you do to stay healthy, is to sleep. Breathe through your nose and sleep. How about that? So, and your memory and cognitive abilities go down. And this is true for adults too, but certainly for kids, the problem is it could be like a permanent cognitive deficit. So, mouth breathing in children. So this is where, like, there's some studies that show that only 3% of kids have obstructive sleep apnea. And there's a couple of problems I have with that. One is, like, to get diagnosed, you have to go in lab to get this tested, and not many parents do. So I think it's underdiagnosed right there. But then even if that was true, there's a lot of patients who are just mouth breathers and have these other sleep breathing disorders, and they're not being looked at. So because it's not like, if a child has obstructive sleep apnea, it's very serious. So, but these other ones are kind of getting overlooked. So, but we know that the prevalence of mouth breathing is between 10 and 25%, and we know that sleep apnea patients breathe through their mouth, sorry. And 80% of mouth breathers at night will also be mouth breathers during the day. So if you're mouth breathing constantly, night and day, that's definitely going to affect your growth and development and your cognitive development. So UARS, that's the upper air resistance in children. This is actually fun. It's a funny photo, but that's how sometimes they can sleep. They're trying to get better oxygen. So if you see a child doing that in the bed, that means they're actually trying to get more oxygen a lot of times. But this has been linked to cognitive impact in kids, bruxism, insomnia, enuresis, bedwetting, and like we said, the neurocognitive. There's the ADHD versus sleepiness. I think a lot of people are familiar with this, with sleep in kids. And it's not that it causes ADHD, it's just that the symptoms look very similar to ADHD. And so, as you know, if your psychologist isn't looking very closely, they're going to just say it's ADHD. So an overdiagnosis of ADHD because of similar symptoms. And so if you look at the numbers of ADHD in America, then and you got to think some of them are misdiagnosed, then there's an airway problem bigger than what we think. So growth failure. So yeah, there's growth hormones that don't get secreted when the sympathetic nervous system's activated and they're not getting refreshed sleep. Neurocognitive damage, what we call permanent learning debt. So snoring, sleep apnea, URS can all cause this learning debt, which just you never get back. So this is one of the most serious reasons why it should be treated early. And I used to say 7, but the problem is a lot of your neurocognitive development happens way before. Certainly your skeletal growth and development, but also your cognitive development is already occurring. So if you just are seeing them at 7, it's way too late for this type of a patient. So what age now? So I wrote 4 here, but honestly it could be even more. I mean, I personally wouldn't be afraid to see them at 3. I'm not used to it. As an orthodontist, we're not used to seeing patients that early. But I would be more than happy to look at them to know where we might send them, you know. So, but I know that, like, ENTs. So we're going to talk about frenectomies still. I promise I'm going to get to that. But they will do the frenectomies, or pediatric dentists or dentists who are doing the frenectomies will do them up to, I've heard up to 6 months. Maybe some will do a year, and then you stop because then you have to go under general anesthesia after the age of, most people say 6 months, some people say 12 months. So this is this period where they can't get any treatment really if they need it, and you're more just working on diet and habits. And as far as like tonsils and adenoids, that's the earliest that will be done is probably 3 because of the general anesthesia concerns. Yeah, so it kind of went over the why the age. So and that video did a great job of describing how the tongue forms the roof of the palate. There's an article that kind of shows that you can tell how the tongue is positioned or how it's being postured or used by the patient based on the malocclusion they have. So just a good example of that is like a class 3 where the lower jaw is really wide and the upper is really narrow and they have a negative overjet. It's probably the tongue sitting on the lower, because you think about the functional matrix theory, it's being pushed and the lower jaw grew more and the upper didn't at all because of the position of the tongue. Now, that also might be influenced, the upper jaw might be influenced by a lack of nasal breathing as well. So there's some of the stuff that it's the art to it. We're trying to figure out, like, there's not a definitive way you can say that this type of patient has this breathing problem and that's what caused the growth. It's a lot of signs, and like I said, it's a puzzle piece we're trying to put together. So, so we do know obstruction alters nasal cavity growth. So mouth breathers typically become obligate. So children with a large adenoids, just like that Harvard study, will become obligate mouth breathers. Nasal cavity will not experience normal air resistance, and that in turn creates less cavity growth, smaller midface, narrow nose, setback maxilla. So I've started to view skeletal abnormalities as airway issues. It's not always the case, because we know genetics do play a role, but it's if the environment is influencing it this way to not go to its potential, there might be a reason. So a non-ideal tongue position, obstructive airway causing mouth breathing, lingual frenum causing tongue tie, abnormal tongue habit or swallow pattern. So these are all reasons that would cause the tongue to be out of position and cause non-optimal growth. So finally, got to the ankyloglossia tongue. So short lingual frenum can lead to a high palatal volt. There's a study that shows predictive of AHI and lower oxygen saturation levels in males. And this is in infants. Short lingual frenum leads to mouth breathing and abnormal development of oral cavity, increasing the risk for upper airway collapse during sleep. And they say 41 out of 63 subjects never received treatment for frenum, even though they exhibited problems later in life. And like, this is like really controversial. I know I just went through it with my daughter, and she actually did have tongue tie, but the lactation consultants some of them didn't even see it. They had different opinions. The one through Kaiser said no. The other private one we went through said yes. So there's a ton of controversy on this in the medical field, in the lactation consultant field. So I think that I would just like have everybody do their own research on it and really get into it and look at the data. And also we have to use our common sense, you know. What's the downside of the treatment? What's the worst case that could happen from doing a procedure as well, versus what's the outcome for the rest of the life? So we do know that ankyloglossia can obviously help improve breastfeeding. And so I'd made the argument that breastfeeding can help develop the jaws the longer we do that. And so if you don't ever get that opportunity, you're already kind of starting behind the 8 ball. Possibly, we don't know, could the frenum on the tongue could cause the tongue to not be able to get to the roof of the mouth and form the palate. However, people are adaptive, and so I've seen some patients that have a really strong tongue tie and their palate looks great because they've adapted out of it. So, but if you're a betting person, you're probably going to say it's probably going to narrow the maxilla or cause growth abnormalities. Allergens can cause rhinitis. So we talked about that a little bit. I think referrals to an allergist really early as well to figure this out, and maybe not medication, but figure out techniques to limit this. You know, I talked about air filtration. That might also go with allergens. So we talked about for the virus, but in your own home or your business, air filtration to get rid of these things. It's all around us and we don't even know it. So. Also, milk, like diet allergies, can also cause inflammation in the nose as well. But if you kind of show this picture to patients, sorry it's so blurry, I've done this before, and they automatically will choose the one on the left. So they know the narrow maxilla is abnormal. I have a patient questionnaire that I asked specifically. I borrowed this from Dr. Rouse in Spear Education. If you want this, it's very scientifically backed on what they ask, but it's not like a standard. There's some standard pediatric ones. I found this one just easier for the parent to fill out. For me, it's more about the conversation starter. Like for kids, at least. I mean, there's the Epworth Sleepiness Scale that is tested for adults as well. But for kids, you're just trying to get the mom or dad thinking about how this relates to airway, because sometimes they don't see the grinding as related, or they don't see the bedwetting as related, or they don't see like the behavioral issues as related. So you kind of want to go through that, and it's surprising if you were to add one thing from the whole lecture to your practice, just add this pediatric questionnaire. It'll change, I swear. You'll start the conversation, and you'll find more people who really need, that were just not even, no one was asking the questions. So that will be sent to you in a follow-up email, though. So this is a terrible slide, sorry. So, Martin and I were just talking about we should not have this much text on a slide. But really, it's more about the mouth breathing and how that causes the narrow jaw, which I think that first video did a better job anyway. This is a little bit about the pediatric PSG. I don't know about Santa Rosa, but a lot of my patients are going to Stanford or UCSF. That seems to be like the lab that has the best equipment. I don't know, I'm not gonna make a call. I don't actually know about Santa Rosa. I would be interested to know if there's a good pediatric PSG here. Kaiser has their own system. I think theirs is in Oakland, I believe, as well, for the pediatric PSG. I haven't had a Kaiser patient yet go there. So let's see. So these are some signs. You see large tonsils. You see long face, gummy smile. You know, if the tongue's not resting, the maxilla can grow down. Allergic salute. You'll see a line. So if they have chronic allergies, they'll develop a line right here, and that's because they keep wiping their nose. V-shaped palate, and then venous pooling or bags under the eyes are good ones to look for, not good ones in general. So the 4 primary treatments in sleep breathing disorder, I did want to throw the pediatric dentist or the ENT for early frenectomy. I went to a class by Dr. Zaghi, Zaroush Zaghi. He's kind of becoming like an airway / frenectomy expert. But there's a lot of guys who do this. For our daughter, we got her, and I'll show some photos of that. We had a pediatric dentist who had a CO2 laser to do it, and if you do that early, it's really a pretty simple procedure. I was in the room with them, and it took like 10 seconds to do the tongue and the lip. I'm not joking about the 10 seconds. So the biggest issue when you do it on infants, though, for the frenectomy is you have to manually massage the area so that the wound doesn't heal when you do the lasers, but for like the 5 weeks afterwards. So it's a lot of work for the parents to make sure this is a successful procedure. But anytime you do a frenectomy, whether it's kids or adults or anytime, you want to include myofunctional therapies, some muscle training. Otherwise, the same thing can happen. It can kind of reattach. And so, in my opinion, the frenectomy for adults is usually out of a necessity from the myofunctional therapy that we're not able to get the tongue seal, we're not able to get the tongue proper functioning, and so we need to release the frenum to do that. So, but there's not a lot of data on frenum release and sleep apnea, like whether it helps. In fact, Dr. Zaghi said you have to be very careful. It could be actually holding the tongue forward for the patient, and so if you release it without myofunctional therapy, it could go back. So I don't think I would ever recommend practitioners just clip it as an adult, do the surgery as with an adult, unless they had some myofunctional therapy along with it, and the myofunctional therapist thought that would be a beneficial procedure for them. That's a whole nother lecture. That could be a whole nother lecture, though. But orthodontics. So I'd like to see them early, whether or not I'm going to treat. The earliest I've been treating now is 4 years old, and I'll kind of show you how I do that. That was my biggest barrier, is how do I treat a 4-year-old with expansion. Surgical orthodontics would not be young children. ENT surgery, nasal sinus interventions, and myofunctional therapists. So that's kind of like the 5 main treatments that I think you can look for in children. So back to breastfeeding. This is the study that showed that the duration of breastfeeding is inversely proportional with the prevalence of habitual snoring. So we think it works through muscle and jaw development, but also it promotes nasal breathing, which if your infant's more likely to nasal breathe, then they're less likely to snore. This is my daughter, Stone. So we took her in at 2 weeks because she was having, not because of Airway, she was having latch issues for breastfeeding. And so this one, the midline, I've got them labeled in lingual. That's like a mirror, so it's interesting. And so it was kind of a combo. It was, I'm really not familiar with the definitions of these frenums, but on the lingual, it was a posterior tie, I believe. So is what the pediatric dentist told me. And so those were, again, it took literally 10 seconds. It's a lot worse for the parents than it is the infant when that happens. But this is a good time to do it when they're born because they don't remember it. There's not a lot of pain. They say the pain receptors aren't built out yet. So this is me doing some of the manipulation of the tongue and the lip. You can see the kind of wound there. Sorry I didn't have better photos, but when she's screaming, it's a little hard to get your iPhone steady. But yeah, if anybody has any questions about that, if they have anybody who has infants or they're suspecting it, because I just think a lot of the normal routine medical community is saying don't do it because maybe liability reasons and it's an extra procedure. But after me personally looking at the data, I think you never know, but you run more risk of not doing it, I believe, long term. And it's so easy. It's such an easy thing to do when patients are young. In fact, in Brazil, it's a law now. You cannot leave the hospital until someone, either a lactation consultant or some specialist, has evaluated them for tongue tie and lip tie, so they can do it before they leave. They view it as a public health issue. So, although I'm just gonna say it's controversial, so don't do your own research. So, what children should or should not use: bottles, binkies, thumbs. I realize how ridiculous this sounds now, being a first-time dad with a two-month-old. We obviously are using the bottle. I mean, we're still using breast, but luckily she hasn't done anything with her hands or the binky yet, so we're trying to keep those away. But the idea is to limit these things like as much as possible. So to promote nasal breathing and jaw development. So baby late lead weaning, again, this I'm going to mention, not scientifically backed, but theoretically to me, it's worth a read. Promoting babies to eat solid foods faster than probably the normal schedules. There's a technique to do it, though. I know it can be a little scary. I haven't got to that stage yet, but it can be a little scary. I've heard from parents when there's some choking, like choking sounds if the food's too. So you want to know what you're doing with that before you. But the idea of it is that if our ancestors had harder foods, we're not doing as much baby foods ground up. That wasn't done as much. They would eat normal foods earlier than what we are. So. Myofunctional therapy. I know a good one, we use a couple. I know a good one in the Napa area. She's my sister. She's a myofunctional therapist. I've been a lot educated on what that is and how it affects orthodontics and dentistry. And so, but their idea of myofunctional therapy is re-education in facial muscles, eliminate oral habits, improve tongue position, improve lip seal, improve nasal breathing, repattern the tongue muscle function, and proper chewing, speaking. These are all really important things for growth and development. I think myofunctional therapists have the most impact on young people than they do adults. Although if you're doing frenectomies on adults or orthognathic surgeries, any type of surgery where you're drastically changing the muscle, you probably should involve a myofunctional therapist. It makes sense. Like if you're getting knee surgery, you'd want to go to a physical therapist before and after to strengthen those muscles, there's going to be a reprogramming of the muscles that's needed as well. So, so in children, there's a study that they improved orofacial tongue and tone in infants and children, and improves nasal breathing in children who've had their tonsils and adenoids. So they showed, as a Stanford study, I believe, showed that tonsils and adenoids plus myofunctional therapy had better outcomes. And so it helps orthodontists by controlling muscle control, and there's some studies that show that it helps prevent open bites from returning. And I believe that if you have one and work with them, then they can be a great resource too for your practice. And myofunctional therapy for apneic patients, so AHI decreased by over 50% adults and 62 who had myofunctional therapy. So just the myofunctional therapy alone helped decrease it beyond just what the actual treatment was. So this is what I was talking about, open bites. So we have more certainty of stability of open bites. And it's never certain, even with myofunctional therapy. But this is a very frustrating item for orthodontists is the return of open bites after we've closed them. Sometimes you close them and there's no problem. And I think that those are the ones we get lucky on where their muscle changes because we changed the anatomy. But it's in my new standard is to send them to a myofunctional therapist if they have a dramatic open bite or even a small open bite, so that after I'm done, at least I know they're doing everything they can to control that open bite from returning. So ENT, tonsils and adenoids removal. There's a study that shows it wasn't effective because they were waiting too long. So, and it kind of why we want to do orthodontics earlier too. If you wait too long, the anatomical changes are set, the mouth breathing set, and oh, you got another question?
Yeah.
Awesome.
In growing pediatric patients that get prescribed CPAPs, can anything be done orthodontically to prevent anterior-posterior deficiency that the restrictions from the devices cause? Binkies are recommended to prevent SIDS the first year.
That's a good point. I did not mention that. So I should mention that because that's a good reason to try to incorporate binkies.
Repeat that 'cause
Yeah. So the first question was CPAPs cause anterior-posterior retrusion of the maxilla because it puts pressure on. So what can we do orthodontically? That's a great question. I haven't had a patient come to me yet that had that. I don't know if those are more significant cases than what I'm treating, but what I've seen others do is start an early and often treatment of reversible face mask. So you've got the CPAP almost acting as a headgear. It is acting as a headgear, and then you do a reverse headgear to reverse those changes. But you don't, like, when do you wear it? So if the CPAP is being worn at night, you wear the headgear during the day. And they have to be old enough to tolerate and be able to wear that. So it can be a real challenge, but it's very important. I mean, if they're a growing child, they have a CPAP, it's very important to their health. You're not going to get them off that. But it's making the problem worse from a growth standpoint because now their maxilla is having a headgear restrictive effect. So the ones I've seen, I mean, if you're proactive with the reversible headgear and they're compliant, you can probably minimize that, but you also might be still looking at orthognathic surgery down the road. And if they don't wear anything, you're definitely looking at orthognathic surgery down the road if they're on it for any significant period of time. The binkies and SIDS for the first year, there is a. I looked at that studies as I was trying figuring out what I mean. Most parents, I think, give them not for that reason, but to help with going to bed and crying. But that is a good. I've seen that, so I would definitely recommend wearing that until I think it is the first 12 to 18 months. Whenever it's recommended by medical professionals, definitely do that. But then the idea would be to get them off as soon as it's not helpful anymore. And so I think that I believe that in in the ancestral societies, I believe how that fits in is that babies maybe were breastfed longer throughout the day. So the binky might be a good alternative to give them something to cause nasal breathing. That's how I think it works, is that the binky actually pacifier acts as a nasal breathing promoter. And so I don't think that we know that for sure, that that's how it prevents SIDS, but we do know SIDS is something airway or something related typically. So hope that answers the questions though. So, so let's see. So ENT, Yeah, so basically the same thing applies. The tonsils and adenoids want to be removed early and often, expansion early and often. And so we find the studies of equivalency of AHI reduction, so you have orthodontic expansion on one hand and tonsil and adenoid removal. They're both about equal, but when you do them together, they're exponentially better. So if there's a serious problem, I think they should both be done together. If it's a more mild or moderate problem, I would be focusing more on the orthodontics first, because there's a chance I think there's some more studies coming out. I don't want to say there is, but I think I've heard some data being thrown around that this can, if that promotes the nasal breathing, and maybe with myofunctional therapy as well, that can decrease the size of the tonsils and adenoids. Because if you believe that theoretically that you're supposed to be a nose breather, and that mouth breathing causes that inflammation, and we've seen tonsils and adenoid tissue return if they are still a mouth breather, then it would theoretically make sense if we can get them to nasal breathe, whether that's orthodontics or just myofunctional therapy alone, or just habit change alone, that would shrink automatically on its own. But my thought process is, when I see patients that have large tonsils and adenoids, I don't just think, oh, that's going to go away, because it's making the problem worse, and why is it there in the first place? So I don't think we should ever just watch and wait, or they'll grow out of it. I think they grow into it, and it's like the damage that was done, growth or cognitively, could be permanent. And so I think the real issue I see with this is that we're looking at the black and white, and so you see those severe cases, and it's like, oh, the obstructive sleep apnea, long face people, long face syndrome, those should be treated, and everybody else, we don't know, we'll just watch and wait. But there's a huge gray area that we are only finding out when we ask questions and you ask their symptoms. There's another app I'd want to throw in there that's called SnoreLab. So I've been very surprised when parents put their phone in with their app, SnoreLab. It'll record any sounds or events throughout the night. Parents are very surprised what they hear. They're like, they don't snore, and then we go through it, and there's multiple snoring events throughout the night, or even talking sometimes. So. Got a little off subject there. So obviously that's me. Orthodontist would be good. Anytime you want me to check somebody out, I'll check them out. It doesn't mean we're going to actually do something, but again, earlier the better. So we know that maxillary expansion alone can help patients with obstructive sleep apnea. So they can go from 10 to 1, and this is in children. And those are pretty significant marks for children. Like even those original AHI metrics were made for adults. So even a child that has a 1 is a significant problem. So the 1-year mark, the sleep study shows normal AHI as well. So it's stable. So what's my priority at Hello Ortho? And we get asked this a lot. Like, what are an orthodontist's goals? And so I don't want to speak for the specialty as a whole, because there's a lot of philosophical differences on what we're all trying to achieve, which makes it hard. I mean, I wish sometimes orthodontists would standardize things a little bit more. And I wish, I think that's kind of why Smile Direct Club is coming up, because if we don't set a standard for what we're about, then people look at it as just tooth straighteners. So, but for me, the straight teeth is the easiest part of this whole deal. If you look at maximizing airway, like I look at it like a 1 through 100 bar, right, for each patient. Airway, facial aesthetics, dental aesthetics, mini and micro, functional occlusion, healthy dentition, healthy TMJ, healthy periodontium. And those aren't necessarily in order for me, although I do give priority to airway a lot of times. Well, yeah, every time. But all the other ones I'd say are, I'm just trying to figure out how to maximize those for the patients. And there's not one patient I've treated where I'd be able to get 100% on them. So, and this kind of falls into, like, is you extract or do you not extract? Well, is it healthy for the periodontium, the TMJ? Is it good for the aesthetics or negative for the aesthetics? And so every patient, you can go through this, and they're going to have a totally different set of standards, I guess, a different set of what we're trying to maximize. The straightening of the teeth is always going to happen on those patients, but sometimes we might leave, like, here's a question. If they have an airway issue and they're significant class 2, they decline surgery, are we going to extract upper bicuspids on them? I would say no. This is obviously a controversy in orthodontics, that you can get a better functional occlusion if you extract upper bicuspids, and I've done that plenty of times in my career. But if I know they have a sleep breathing or a suspected even, I'm going to be very hesitant about doing that. But every patient is unique, and this is why sometimes dentists probably look at orthodontists and think, well, why did they do that in this case? I think they could have gotten better occlusion, or they could have gotten better aesthetics. Why did they extract this patient? Because I think they have airway issues. And I think this is just a conversation that should just be had on a one-on-one basis with each patient with the orthodontist, because your orthodontist has the best for your patient at heart. It's just that sometimes philosophically we have different ideas of what the best is. So that's why I think those conversations should be happening on every single patient. So kind of moving on, again, what I'm doing with expansion and how expansion works. I think the visuals are better, but we have this V-shaped phenomenon that happens from the mid-palatine suture, so going up to the incisive papilla area to the posterior maxilla. It opens up wider, and that's why you see a diastema when you do these expansion cases. You also have a V-shape from the maxillary. The maxillary halves kind of go like this as well. So there's two dimensions of V-shape. I don't think that's ideal. That's what ends up happening because of the resistance points, though. Oh, I would say this happens less. So the research showed this happens less in younger patients. So the younger we get them, the less V-shape there is. And this is, I think, the key to the physiological changes in the airway, is to not have as much V-shape. So I believe this, and this is also controversial, I believe that one of the points of resistance is the pterygomaxillary suture, but I've talked to some oral surgeons that say that might not be the area of resistance. But all we know that over time, these sutures start to fuse. And so we have infancy, juvenile, adolescence. So what we found is the suture actually never completely fuses. It just gets more convoluted. So let's see if I have one more. No. So you can see it goes from a very basic suture line to more interdigitated. And then even as an adult, it's interlocked so much you cannot utilize the suture for growth anymore. So in orthodontics, we capitalize on this through our expanders early because there's not much sutural interdentation in the mid-palatine suture, and we can really widen that jaw. Now there's no suture on the lower, so we'll talk about that, about how much do you expand. Let's see. So this is always talked about in orthodontics, and people are like, well, how much do you know to expand? And so if they're a sleep apnea patient, it's completely different rules probably, or you suspect sleep apnea even. And I say that because ENTs can treat on, like I would never treat based on symptoms, but ENTs can remove tonsils and adenoids without having a sleep study done. They can just go off symptoms. But because I can't diagnose it, I can't treat off of just symptoms alone. But what I can do is look and see if there's crowding or there's other dental issues, or I see a transverse deficiency. I will treat it and know that I'm doing a good thing for the patient as well. So we have to diagnose dental deformities, dental problems, and treat those. And I like just being knowledgeable about the airway as well, because it makes I can track it. I can see their questionnaire before and after I do it, and a lot of times it's dramatic improvement. So, but how much do you expand? My idea would be it's more of a qualitative measure. We want to decrease the symptoms. But there's also the realistic of the lower, depending if they're tipped in or if they're upright or kind of tipped out. That's our limiting factor. So I do, for my phase 1 orthopedics, I do a lower expander, but I'm not fooling myself. I'm not expanding the lower. It's tipping the lower out. Maybe you're getting a little bit of alveolar bone augmentation or alveolar bone increase, but this is not well studied or well researched, so I would never say that's what, basically what my entire goal is to upright them so I can expand the maxilla as far as I can, especially with patients that are symptomatic and or diagnosed by a physician. So that would be my preference, to have them be diagnosed by a physician. Then I know that we're doing the right thing, and we want to go as far as we can, but that's a rarity I'm finding, that it's not even be looked at, and certainly no one's getting these in-lab children's studies unless it's a very severe case. So there's some normative values of 32 to 38. I get asked this, well, how far do you expand? And for me, I try and stay away from numbers because I think you get looked into it. Like some patients might need less, some patients might need more. I think that the more I'm learning about myofunctional therapy for helping them out is that we need to look at how does their tongue respond to how much we're going. So there's kind of an interplay between disciplines. If it's on an adult and we're upright in the lower and there's so we're trying to do some sort of expansion. I'll go over the techniques for that on an adult. But the lower there's thin periodontium. Well, that's when the SFOT or Wolcodontics or whatever 500 names they have for those is useful because then we can upright the teeth more and increase the biologic limit of our movements. So this is the stresses. You can kind of like visually see where the stresses are of the maxilla, where the pressure points are. This is one reason why I try to put my expanders on baby teeth if I can, if we're doing it on mixed dentition or primary dentition. I'd rather not put the pressure points on adult teeth because I think that's where you start to see periodontal problems with them later in life. This is like an area over the pterygotalatine suture where I think a lot of the resistance is. Let's see. This is just a lot of text, so that kind of just again shows the V-shape expansion. So there's even they're finding when you do expansion on children, you find pressure all the way up to the frontomaxillary suture. So what you run into is the younger they are, you're expanding the maxilla mostly, but you're actually there's a lot of structures above the maxilla that you're getting slight expansion. And one of the reasons why I do I do a hybrid expansion. We prime it, we put a lot of pressure on it, and then have it go slower. Is we don't want too much. You know, when they did the early studies when they did rapid palatal expander, some patients would get a wider bridge nose, and so we're trying to have the effect on the maxilla only. And then some structures above, but we don't want to have too much expansion in places we don't want it. So. Which can happen, especially with depending on the technique that you use. So this was in young patients, I think like mixed dentition patients. So you can see that in these patients, the posterior and the anterior were pretty similar. But as the patient gets older, it's going to be more anterior expansion only. And then you also get more tipping of the maxilla this way. So you really want...
If you have a look at this boy, you can see what happens when we change from an incorrect tongue position to the correct tongue position. Once those bad habits have been changed, you can notice...
Okay. So they're both playing at the same time. So let me go back a little bit actually. So just a little bit of history of expanders have been around forever, and so I wanted to kind of talk about the myobrace and the myomunchie are.
If you have a look at this
kind
boy,
of like the earliest.
You can see
What are you going to do on someone who's 6 months to 3 years old when you're not going to get them to put an expander in, basically, and this is what I view these are as aids to myofunctional therapy. So if you're using the pacifier until the recommended age, then maybe you transition them to a myobrace or a myomunchie, which just helps the musculature support. I haven't done a lot on kids actually this young. That's when I think it's the most valuable. I've tried it on patients who were not willing to do expansion with me, but I just want to try out the myobrace, and I just charged them the fee of what the myobrace is that I get it for, which I think is like $75. And so, but I've been disappointed with even the ones who wear it. I've been disappointed with what it's doing. So my biggest issue with myobrace is when there's some dentists who are claiming it has as good of results as what we're doing with orthopedics and or orthodontics, And so they kind of have a marketing as like an alternative to orthodontics. And if you charge the same amount of it and you don't get as good results, then that's when I have a problem with it. So I don't mind. It's a great product for trying to get their muscles improved and trying to. It's almost like a myofunctional therapist in a box. It's like it's trying to get them to put the proper tongue position, proper lip position. I've just, me personally, when I've used it, I've been less than impressed with the actual outcomes of it. And I think you have to have dedicated people that wear it for a long time. So I believe I can get better outcomes if I just kind of delay it a little bit and use an actual expander on them. But if there is a real issue with compliance or ability to tolerate a cemented expander versus a removable. So all I think of the MyoBrace is they took the idea of the Frankel, which was very popular in Germany, in East Germany, by Dr. Frankel, but it takes away the cheek and lips. It pushes them away, and so the tongue naturally just pushes on the jaws, and you do get expansion, and you do get improvement in alignment. So the idea was to make a non-custom one of those with a MyoBrace. So some other things that I will be doing on younger kids that I think is better than a MyoBrace would be either a Crozat or Invisalign first. And I don't do a lot of Invisaligns on kids, but I think it has some merit because if you get them early enough, Invisalign will expand them. A Crozat will expand them. A MyoBrace would expand them if they wore it. But I think that a MyoBrace is more uncomfortable to wear, and also it can be easily spit out at night. A Crozat, if you design it right, can be clicked in by the parents and hard to take out. So would Invisalign be very difficult to take out. Now the thing is, we don't know, is the plastic enough to expand? Probably if you get them young enough, I think it would be. So these are like newer techniques I'm thinking about doing. I don't really have any data or I don't have a lot of people doing these that I can bounce ideas off of. This is kind of like, forefront stuff. Now, if they have a true sleep apnea issue, there are some orthodontists that have hospital privileges that can cement the expander while they're under general anesthesia. I don't do that. So if they're a severe problem, I'm probably going to refer them somewhere else, so that like UCSF or Stanford to get that type of treatment with a team, like under team care. But this is courtesy of Dr. Brian Hochul. I was supposed to be taking a Crozat course with him in his office last weekend, but of course it got canceled. But he sent me some of these photos that show like how the Crozat looks, and there's some controversy here. Like there's ALFs, I forgot there's another appliance. I think the biggest controversy is like when you're used on adults, like what are they doing? So I don't think that you're expanding the maxilla with a Crozat in an adult. I think you're just tipping the teeth out, and the same as the DNA appliance. And I've seen cases of people come back and their bites look terrible after they've used some of these appliances that are just like tipping the teeth. That's all they're doing. And so the lecture's not a, oh, go ahead.
One more question.
Yep.
Do you or any of your colleagues do any intraosseous expanders?
Intraosseous expanders. Oh, I think I know. TAD supported. Okay.
Repeat the
Yes. Okay. Intraosseous expanders. I'm guessing that it means TAD supported expansion, but if it's not, maybe clarify it. So TAD supported or mini screw supported expansion. Yes, I do, and I've got some cases to show that. So I've never heard intraosseous expansion, but it makes sense as they're expanding intraosseously. So anyway, so I don't. The whole lecture is not about like talking about, like, all appliances are good to expand, but we just have to be realistic about what we're doing with the expansion. Anything can be, that's why any device you use, on the younger they are, that's going to work, right? But as you get to adults, you'll see why I do the TAD supported expanders, because I don't believe that, I don't want to just tip the teeth out and expand it that way. That's not going to give me the physiological improvement, and especially for the airway patients. And you're going to get, like, so functional occlusion, if you tip teeth out this way, and on the lower, you're not going to have, you want upright teeth. And so your functional occlusion is diminished as well. And periodontally, you probably might compromise the patient as well by doing uncontrolled tipping. Although, I guess you could argue that tipping would be better than bodily movement if you don't have bone. So, okay, so those are great. That's a great question. So I'm glad you guys are listening. So this is another study talking about how expansion helps with airway and general health. So that's why I'm passionate about expansion, because if I can promote oral health in kids and adults, then beyond just their teeth, it's a very cool thing. So this graph was probably designed before the TAD-supported expanders, so we need to add a separate column for that. So we have removable fixed, tooth-borne, and tissue-borne under the fixed. So there's all sorts of expanders that were designed, and they have pros and cons. You know, this is the Haas kind. So the theory was you'd put these acrylic plates on it, it would put pressure on the maxilla. I think that these are going to fall out of favor now that we're doing the TAD-supported or mini-screw-supported or intraosseous maybe expanders, because whenever I've used these, it just presses into the tissue and just necroses the tissue, but I don't think it's actually expanding the bone. So now I would say some orthodontists love these, and they maybe have better results than I have. I've always stuck with when I've done orthopedics on mixed dentition, I've always stuck with a Hyrax type of expander. But now that we have scanner and 3D printing, we're doing 3D printed bonded Hyrax expanders, which I think has the advantage of controlling the vertical more than like the reason why you used to use bonded expanders with the acrylic, they're very unhygienic, and I have a photo of it, is the theory was you control the vertical so the maxilla wouldn't grow down, but also you'd get less tipping of the maxillary halves. So if you bond it on the teeth, you're going to get less of that V-shape expansion, which is better for the occlusion, better for airway. So you might see like slow versus rapid. I took this off of another person's slide, but it had a good rundown. So if you hear rapid palatal expander, like the way they were originally used was the standard type of jack screw is turned twice a day, and it has a leaf spring niti that exerts light pressure. So my thought is open the suture with some heavier forces, and then allow the niti spring to gently expand the jaw, and so trying to get best of both worlds, less side effects, but maybe more quicker resolution of the problem. So similar to what we use, this is a standard Hyrax. I rarely use them on adult teeth because I don't do a lot of adult expansion without TADs. And so there's a lot of orthodontists that we used to use or do use these. I think though that unless you know the sutures can open, then you're probably running the risk of just moving those molars and premolars outside of the bone. So I don't think it's a great idea. I mean, once they hit age 10 or 11, I'm starting now to transition them into the TAD-supported expanders, because you start putting pressure on the teeth, and then you're unsure whether you're getting that as much expansion in the sutures as you need, and so all the pressure gets exerted to the teeth instead. So I use a leaf spring expander. This is made by Leon, and it has a jack screw on it, so you can pre-activate it, and then the leaf spring expands, and then you have them come back, and you reactivate the leaf spring. So the parents don't have to deal with turning the expander either, which they love. That's been a huge, so the upper and lower expander we use, parents don't have to deal with it. So this is what I was talking about, the bonded expander. I've never used these because they're just incredibly unhygienic, but I've always wanted to use them because they control the vertical, and I think they do a better job of getting that, controlling the halves of the maxilla to expand. So we use a bonded, it's a 3D printed, it's not a band, it's actually more like an on-lane crown. And so we bond that on, which gives a similar, and sometimes we'll do the premolar area or baby tooth, and we'll bond that as well. But it just allows us to do it do the bond expander much more clean. So And there's no separators with this system. Yeah, it looks like that. There's no system, there's no separators, so it's all just bonded on. And then on the lower, like I said, we do different types of expanders. We do E-arches, Wilson arches. Sometimes we'll use braces because I know there's no suture down there. So I'm not trying to expand any sutures. I'm just trying to upright the teeth and maybe get a little bit of dental alveolar width with the primary dentition. Because my hope is the more bone if I can move a baby tooth and some alveolar bone comes with it, then hopefully the adult teeth erupt and there's just more bone. I don't have any data to support that. What I found in my own cases is they tend to have a lot more alveolar bone on the lower than how it looked at how it started. So, but regardless of that, I'm trying to upright the teeth. And most of these patients that are transverse deficient have tipped in lower teeth. Okay, so these are some cases. You can see perfect example of narrow maxilla, tipped in lower. Also the baby cuspids are missing. And so I have a CBCT, ICAT. We do volumetric measurements. I don't think there is. When I first got it, I was like really excited about it. I took a class from David Hatcher and realized that there should be laying down first of all, because that's what when you sleep so this is a very static image. It's not dynamic. If you see like companies that show you that they took them from the red to the green to the blue, like, well, great. Like, what? That doesn't mean anything. It's like they could have been the way they took the X-ray. But also, even if it did expand the airway, it doesn't mean physiologically that you help their breathing. So for me, it's just another thing to look at, and it's been very educational to see. Like, you can see tonsils or you can see the adenoids very well on it, but you can still see those same things on a cephalometric X-rays. Actually, if you know what to look for. So. So the benefit, the benefit of CBCT as far as airway is more for doctor education and really looking at all the. It's surprising how many patients have deviated septums as well when you start looking for it. So, you definitely can see more, but you can do this dentistry without having a CBCT. You can integrate it in your practice. It's not the number one thing I'd go and get to be able to incorporate things. So. This is him after the expansion, and so you can see one of the he's got some permanent teeth coming in, but this is stuff I would be doing anyway. Although not always. I used to maybe save that person and extract teeth when I first got out of residency. But I think that what I've learned about airway, I want to maximize this guy's bone, maximize his arch forms, and he did, so I didn't mention that, but he did have snoring, his sleep issues, and you can see he is a vertical grower, and the symptoms were lessened during the treatment, Mom stated. So I wish I'd have what I'm going to start doing is actually keeping better track of the pre-survey and the post-survey, just like to numerically quantify it. Because I think that's the most important thing. That's the most important thing to quantify besides photos, obviously. Another patient, open bite expansion. I thought I had the names crossed out. Don't look at the names. So she's even though she expanded, she still has this open bite issue at the end of the orthopedic phase, and she was sent to myofunctional therapist to work with that. So even though we have more room for the tongue, it doesn't mean it automatically solves the issue. And so we set her up for a better environment to be able to now hopefully control the muscle. So we changed the anatomy first, then it helps to improve the muscle. Now sometimes we were lucky, and just by changing the anatomy, the muscle it kind of disrupts the muscle function, and then they go back afterwards to a normal function, and the open bite will just close automatically actually. So what about if we miss the opportunity? So like age 10 is when those sutures start to fuse. Kind of the only thing we had in our toolbox a while ago was the SARPI. So So we'd kind of wait till the patient was older and stopped growing, and then we'd do the surgical cuts. The issue we found with this is it does great expansion surgically, but Dr. Stanley Liu in Stanford, oral surgeon, I just went to his lecture of his, and he shows data that shows that even though you expand greatly with the SARPI, it doesn't necessarily physiologically help the airway. And so, you know, they do these 2-piece maxillary Laforts or 3-piece, and you can get great occlusion, you can get widening. Sometimes you talk to different oral surgeons, they'll say some are more stable than others, you know, and I know some oral surgeons like to do a SARPI first and then orthognathic, or now do a TAD supported expander then orthognathic. But the real issue I have with orthognathics only is that the expansion, you kind of lose that the benefit of the orthopedics by surgically cutting, because if you think about it, wherever you cut, that's where it'll be, everything below that will be expanded, but nothing above that will be expanded. Whereas if you can do orthopedics, you may be able to expand the structures above where the normal SARPI cuts are. Sorry, I'm just rolling. We're almost to 2 hours, but this is going to be perfect timing, actually. So these are the more modern approaches. I think, in my opinion, and I'm talking about airway specific, not all problems, but more modern adult expansion approaches. We have the MARPI, the dome procedure, the ease procedure. All have different, I guess, inventors or people who are pushing it and passionate about them. I've learned from all of them. I consider them all great mentors and colleagues. So this is the MSC. So there's no cuts. It's just, and a lot of orthodontists are putting these in. I don't put these in myself. I have an oral surgeon put the TADs in for me. But you're placing them bicortical anchorage around the midline suture. So the bilateral is the key. And then if we're lucky, you get sutural expansion. So when I say that, if you're lucky, what my colleagues have been finding is that a lot, like females are good at any age. I mean, I've seen cases pretty predictably 60, 70. Sometimes you get a couple that don't work, but females, for some reason, as a broad statement, have more predictability of actually getting adult expansion, orthopedic expansion with the TADs. So there's no surgical cuts. You actually, the TADs allow you to like return them to the age of when they were 7 and 8 or younger. And so, but it's a little bit less predictable as they get older and if they're male. So I haven't done enough of these to know myself. I'm going off of colleagues, and it's not new to Juan Moon, who kind of the guy who's invented it and has this MSC type expander. But and I would say there's lots of different groups doing similar ones to these. I'm not saying he's got the only one, but he's like popularized it and made it an easier to use one, basically. But he's also gone through the growing pains of like when it works and when it doesn't. So there's a big user base for this, actually, that's happening. So when you start to learn what works and what doesn't. But the thing I like about it is it not only expands the maxilla, so if you had a crossbite or if you had a narrow maxilla, it helps with tongue space, but you get more physiologic change because there's no cuts. So the cuts are always going to be the most resistance, but also help expand structures above the maxilla. So this is just kind of like the pre-planning of how you place them. And again, I think the pterygomaxillary suture is one of the biggest resistance points. And this is why sometimes on males you'll bend the TADs, or the expander will become buried if you don't unlock the sutures. And it's not I don't think it's the mid-palatine suture that is the resistance point, although there are some people that do corticotomies along the mid-palatal suture because they think that might help, and it's the easiest thing to access. But I don't think that. I think if you kind of go more of an age demographic approach, then you reserve this for younger patients and maybe female patients or really less dense bone patients. But then if they're less dense bone, then you always worry about the TADs slipping as well. So I'll be honest, I've done 2 cases, and I've learned a lot more about it by taking classes and through colleagues. But I think that this is a great approach for patients who miss the boat on their orthopedics and aren't willing to do surgery. The cost on this is dramatically less than a SARPI, dramatically less than some of these other procedures I'm going to go over, certainly less than orthognathic surgery. So it's worth a shot, is what I'm saying. But this is going to happen if the sutures don't. The TADs are titanium, they will give away. This is one of our patients who found us. She's been diagnosed with upper airway resistance syndrome and researched everything. She was going to go with an alpha appliance, but then on her own found the MSE appliance and was referred to from us for it. And I'm glad she did. I don't think an ALF would have given, I mean, it might have expanded an ALF is like a Crozet type of appliance, but an ALF or Invisalign or braces, they all could expand her teeth, but they can't give her that skeletal expansion that I think she's looking for that will be beneficial for her. So this is not her, this is another patient, and kind of just talks about how you activate it. But this is when we started, and this is a couple weeks afterwards, so you can see she's already getting diastema. It took her a while. She didn't have she didn't have any symptom changes until a couple months, but this is still in her right now, actually. And then a couple months later, I took another one that shows. This one shows really good parallelism of the sutural opening. And so we kept going from there because we know that the suture's open, and it's actually very easy to expand once you get that opening. She said it felt like a pop, almost like a knuckle popping. It wasn't painful when it happened. And then you can see the blue was the before, the white's the after, and that superimposition of how much volume changes we're getting and how far up it goes as well. And so the best case scenario is you get so this is showing the difference between a normal expander and a TAD supported. A normal expander is going to, again, have too much tilt in an adult, and you want to have more parallel expansion. That's what helps the physiologic change of, especially with the airway. It also helps functional occlusion to keep the teeth upright. And so Dr. Stanley Liu and Audrey Yoon have kind of developed this technique called the dome procedure. And what they do is, instead of a SARPI, they do some cuts along the midline suture, and they go through the nose endoscopically, so minimally invasive. And they also cut along the, well, that's a good question. I have the cut somewhere. You know what, I have that in another lecture about exactly where they cut. But this is a variation of a SARPI. And this patient, you can see very, very crowded. They actually extracted teeth. Oh, here we go. So the piezoelectric saw the mid-palate suture, and then they wedge that open, and they also do a level 1 osteotomy. Okay, so this person had extractions done and the dome procedure. Sorry, it's blurry. This is not my case. I got it from their website, from an orthodontist who worked with Dr. Liu. But they extracted, but you can see they have a lot of expansion as well. So this kind of case where they might need both. So you extract and you expand to preserve and help the airway as well. So I don't remember on this case what the AHI reduction was, but he said, when all these things, there's never a cure for sleep apnea, but the MSE, the dome, and this one, the ease procedure, are all AHI reducing procedures. And for different patients, there's different amounts of AHI reduction. And so even on a patient without sleep apnea, if they had URS, I would imagine there's going to be studies coming out that show that it helped that. But this is such a new thing. It's like new uncharted territory. There's not great data, but Dr. Casey Lee did come out with a pretty good article, if you look up the ease procedure, on by how much on average his patients have been reduced. So sometimes they'll do these procedures first, and then they'll do an orthognathic jaw moving forward procedure, an MMA procedure. And so you kind of get the benefit of the transverse and then the AP later if you need a secondary surgery. But this is much more minimally invasive than an MMA surgery. And so you kind of want to see what you can get with this first. Again, ideally, these patients would have came into an orthodontist earlier. Like, age 7, 8, 9, and dealt with some of the stuff earlier. Now they have to have cuts, and they have to have TAD supported expander. This is also a TAD supported expander. It's called a on-plant, and his cuts are a little different. He does the mid-palatine suture, and he also does the pterygopalatine suture, the one that I think has the highest resistance, which makes sense to me that he's getting more parallelism of the maxilla and like less diastema, but I think more parallel expansion, which is what I look for in the kids who I'm expanding. So, and this is kind of an image from the article of him going with an endoscope to try and be minimally invasive. So that is all I have for today, and I ended 5 minutes early. So if there's any questions, then that'd be a great time at the end of the lecture to answer them. Sorry, that was I'm a little I'm in a brain fog right now. So no questions? We're good. Well, thank you guys very much. I appreciate you, and stay safe at home. You know, social distancing. It'll be over before you know it, and we'll be back to work. And so study up on Airway between now and then. Okay. Oh yeah, there'll be a quiz on the way. We're gonna send you five questions to make sure you weren't playing Tetris during this lecture. All right, thanks. Bye bye.